All right.
Deep breath.
I think I got you.
Hope so.
Alright. Stephen Jones, a father of two beautiful little girls, suffers from chronic pain and is prescribed hydrocodone. His physician told him to take one dose every 8 hours as needed. One evening, as his kids were playing outside and his wife was cooking dinner, he collapsed. He stopped breathing and was having mild seizures. His wife immediately called 911 and explained everything that had happened, and they responded by saying, "We'll get to you as soon as possible." His wife didn't really know what to do and just waited. No one showed up for 35 minutes. By this time, Stephen was completely still and had no movements. When the EMTs arrived, they pronounced Stephen dead. After the autopsy came back about 9 weeks later, it was determined he had died from a fatal opioid overdose. In this case, Stephen Jones was just one of the 115 Americans that die each day due to an opioid overdose. According to Todd Speranzo from PR Newswire in his 2018 article, 77% of opioid overdose deaths occur outside of a medical setting, and more than half occur at a home. And the rate of fatal opioid overdose deaths are only rising to this day. With the rate of opioid overdose deaths on the rise, it is essential that the public stands up and takes a stand on this issue. The public must be the advocate to get the addicts life-saving treatment that is needed to reverse the effects of an overdose. In order for the public to take a stand and be an advocate for the addicts, it is very important for us to look at the problems, causes, and solutions to this growing epidemic. As stated by Alexander Wally and his co-authors in their 2013 article, since the mid-1990s, there has been a massive increase in fatal overdoses due to the exponential growth in prescriptions for opioid analgesics and their non-medical uses. There are two major problems associated with this opioid overdose epidemic, which include the doctors over-prescribing opioid medications and the emergency personnel response times. First, there has become a culture among physicians of wanting to constantly please their patients, which is both good and bad. Physicians went through an intense school process in order to help their patients to their best ability. However, some patients take advantage of the willing physicians to obtain prescriptions for non-medical uses. These types of people are called doctor shoppers, which are defined by Wally as individuals who had Schedule II opioid prescriptions from 4 or more prescribers and filled prescriptions at 4 or more pharmacies in a 12-month period. Doctor shoppers are a big part of the problem of the extreme amounts of opioids out of pharmacies and onto the streets for non-medical purposes. Secondly, once someone suspects either themselves overdosing or witnesses someone else overdosing, they will usually activate the emergency medical system, or EMS. According to Charles Courtmonkey and his co-authors in their discussion paper of August 2017, the National Fire Protection Agency Association recommends a 4-minute response time for basic life support and an 8-minute response time for advanced life support for all emergency services. However, after the complete installment of the Affordable Care Act in 2014, there's statistically significant evidence that the ACA resulted in fewer ambulances arriving within 8 minutes, and the overall response times were slowed by about 2 minutes. This means that thousands of opioid overdose patients could have had life-saving treatment if the ambulances were able to provide quicker care. We have looked at how the prescription opioids have entered the street through doctor shoppers and the issue of ambulance response times. Both of these issues have contributed to the opioid crisis. However, there is a simple underlying cause that has fueled the fire for the rate of fatal overdose deaths: doctors. Doctors have prescribed opioid painkillers for people who state they have chronic pain. Doctors have created an opioid-dependent population, and when 38 states recognized that a significant portion of prescription opioids were being diverted and abused, they created prescription drug monitoring programs. This database helps to monitor the doctor shoppers we talked about earlier. Now that there are more regulations to obtain opioids legally, many users who feel like they need opioids to live turn to illegal substances such as heroin, fentanyl, and carfentanil, according to Richard Reisman and his co-authors in Prescription Opioid Usage and Abuse Relationships of 2009. Now that there is a slippery slope of an opioid-addicted population that is either addicted to prescription opioids and or illegal opioids, there is an inherent risk of overdoses. In order to protect the lives of potential opioid overdose victims, naloxone or Narcan Community access and education is essential as recognized by Todd in Opioid Overdose Prevention of 2017. Narcan comes in several forms, however, I'm going to detail the nasal spray. According to the Narcan official website, Narcan nasal spray is the first and only FDA-approved nasal spray that can counteract the life-threatening consequences of opioid overdoses in emergency situations. It is simply administered by pressing the plunger of the applicator while the tip is in the victim's nose and then repeated after a few minutes. If difficulty breathing resumes or no respirations are present, and according to Maya at Time magazine, the cost of Narcan is well under the threshold that should justify its use. The drug costs just $438 per quality adjusted life year, and generally costs under $50,000 per quality adjusted life year are considered economically sensible. The nasal spray also has a very low risk of causing more harm to the victim. For example, a needle and syringe dosage of Narcan could present the risk of causing a needle injury, whereas a nasal spray has very minimal risks such as nosebleeds. Overdose education and nasal naloxone distribution, or OEND, programs were implemented in Massachusetts, as discussed in Wally's article in the BMJ. Two key elements of the OEND programs were the support of broad implementation of the nasal naloxone delivery device and the use of a standing order issued by the health department, which allows non-medical personnel to deliver OEND. With more trained people with easily accessible doses of Narcan, it can significantly decrease the death rates. For example, if the educational programs aim to educate and provide Narcan administration tools to opioid users or family and friends, these people will be within 4 minutes of the overdose person and will be able to administer Narcan while the EMS personnel make their way to the location. This is very important to note because for people who live in rural regions, there is more of a delay of the EMS services to arrive. With the readily available Narcan doses, close friends or family will be able to administer the powerful opioid overdose reversal drug and potentially save not just one life, but 2 or 3. Even though doctors may keep prescribing opioid painkillers, more educational programs are being established every year and more people are being trained to be able to recognize the signs of an overdose and to administer Narcan to overturn an overdose that they witness. So think back to Stephen Jones. If his wife had a Narcan dose readily available in the household, Mr. Jones would be able to watch his children go to prom, graduate college, and get married.